So I'm going to do a quick little introduction, but I won't take too much time since we're already short on time. But I'm really excited to introduce your speaker today, Dr. Pinto. She was actually one of my brain injury attendings when I did my fellowship at Carolina's Rehab in Charlotte. And she is now an associate professor at the Department of Physical Medicine and Rehab in University of Texas Southwestern in Dallas, Texas. She did her med school training at University of Pittsburgh, and she did her residency and fellowship training at UPMC. And she is also the co-project director for the North Texas TBI model system site. And she has a grant from the National Institute of the Neurological Disorders and Stroke to study what she'll be talking about with us today. And on a personal note, Dr. Pinto and I both have dogs named Pepper with mood and anxiety disorders. So that's something that we bonded over when we were working together. So thank you so much for being here with us today.
Great. And thank you for that introduction. So just go, we're gonna go. Okay, so my disclosures, just kind of just highlighting the funding sources that are going to be part of the research that I'm going to be talking about today for this. The big things I want to kind of go through, and it's going to go through kind of everything that we're doing right now in our brain injury in my lab. And so it's a little bit of a broad spectrum of them, but I'm going to go over kind of the association between TBI and cardiovascular health, the impact of poor cardiovascular health on the outcomes after brain injury, and then start kind of moving into some of the autonomic nervous system dysfunction and TBI and how that also is related to outcomes after brain injury. So to start, I'm hoping that you all had seen that TBI was recognized as a chronic health condition officially by Center for Medicaid and Medicaid Services, or Medicare and Medicaid Services this year. And it's starting January, it's going to be listed under one of the chronic conditions covered in the special needs plans. And so this will be interesting to see how this really plays out into practice, but at least we're getting this recognition that this is a chronic condition that requires long-term treatment, not just that very hyperacute phase and the early rehab stage. This is all based off a lot of work that has come out. Pretty much the earliest time that you really see this published and this conceptualized was now 11 years ago with this landmark paper by Drs. Corrigan and Hammond. And then last year, there was this paper looking at the traumatic brain injury model systems and really did a nice deep dive into all the aspects that are impacted by traumatic brain injury, going from just kind of like the functional outcomes, cognition, but also life satisfaction, mood symptoms, and everything in that realm. And so these are really good papers to reference and really have conceptualized this. One of the interesting things with traumatic brain injury is that there is an increased risk of death after brain injury, and it's not necessarily related to the underlying condition. And so you can see here, this top line is that this was a study in the model systems. It was now 12 years ago where they looked at patients that were enrolled in the model systems. And then they just looked at, death and compared to the standard population where you're looking at age and race matched and sex matched individuals in the population. And what the SMR stands for is a standardized mortality ratio. And you can see that overall patients had a 2.25 higher risk of death than the general population. What's even more striking is when you look at this column where they break it down by age, and you actually see like even the youngest population actually had the highest increased risk of death. And then that effect kind of diminished over time. And that's, probably not too unexpected because of the fact that the life expectancy when you get to, your upper 80s is already pretty short, but it just really conceptualizes the whole fact that it's impacting people kind of long term and has some really detrimental impacts on health. And so there's been some kind of thoughts as to why I am just really going to focus on cardiovascular health for my area of interest. And 2 years ago now, this study came out and it's looking at the long-term effects of in the military cohort. And this was over 1 million people that were post 9/11 veterans. that were enrolled in the VA. And you can see pretty strikingly, if you don't have a TBI, your risk of having any type of cardiovascular condition, which they based on ICD codes, actually is much lower than patients with any severity of TBI. And the risk increases with increasing severity, kind of giving you an idea that there's some type of a dose effect. And interestingly, when they looked at this, really the highest risk of having these cardiovascular complications is really kind of the first few months to year after the injury, but you're still seeing it elevated time since the time post-injury. This kind of follows up with some data that we had, and this was published earlier this year in the Journal of the American Heart Association, where we looked at the traumatic brain injury model systems cohort. So that's going to be your, as you guys are a model system site, you should be familiar. This is your complicated, mild to severe traumatic brain injuries, get admitted to rehab, and are followed at that 1 to 5 years and 5 years thereafter. And we actually compared it to the NHANES, which is the National Health and Nutrition Examination Survey database. And the reason we use that is a number of years ago, the model systems had added in these questions that we refer to as the NHANES questions. And those are ones where we are asking people, have you ever been diagnosed with these conditions? And so we looked at ones that we were able to easily marry between the two databases. And we looked at kind of the prevalence of that. And this data, which is really interesting, we actually ended up controlling for age, sex, body mass index, and a number of other factors like education level, smoking status. And we looked at it cross-sectionally at the patient's last interview that we had and compared it to the cross-sectional nature of the NHANES database. And so with that kind of background of how we did this, you can see that there's a elevated risk of hypertension and stroke in this in the database for patients that have brain injury versus not. But interestingly, we found that there is a lower risk of congestive heart failure and heart attacks, which we were puzzled, and we aren't thinking that it's protective in any way. So we started looking at this a little bit more granularly. As I mentioned with the mortality, you saw that higher risk of mortality really in the younger age groups. And so maybe it was something with an age aspect that we're looking at. And so we dichotomized it based on the age of 50 because that was around the median point of our sample. And you can see that the effect really, you still are seeing the hypertension, the stroke. There's no difference in the heart failure, the heart attack. And then you start to only see that it's a little bit lower for the patients that are over the age of 50 at time of interview. Which we thought, again, was still a bit surprising. We wouldn't expect TBI to be protective for people once they get older for having these conditions. And then when we looked at it for the time post-injury, so patients that were the less than 5 years, which meant this was their 1 year and their 2 year follow-up versus the people that were 5 years or later, you really end up actually seeing that the congestive heart failure rate was actually a little bit higher in those first 2 years, and the heart attack is still not significant. And then it's when they go a little bit further out that you're seeing this weird effect. And as I had mentioned, we looked at this cross-sectionally with the last interview that they had. And one thing that we were really concerned about when we were conceptualizing this data and trying to explain this, what's really unexpected is we were only specifically asking at that last interview. So say we interviewed somebody at 2 years, they've never had a heart attack before. They'd answer that no, and then they didn't make it to their 5-year interview because they died of a heart attack at year 4 or something. They were now out of that database. So we're concerned that there might have been something with a mortality aspect. And when we looked at the rest of the literature, for the most part, people are not breaking out congestive heart failure or heart attack. They're looking at heart disease more globally. So that was another thing that we thought was a little bit different. These conditions are a little bit more severe and might have led to fatalities. And to look at that in this database, we did actually look at patients that had died before year 1. And since these questions were not asked at baseline, and I do appreciate Jenny's work with the data committee to letting us get this in. Now it's going to be asked at baseline. we were concerned that maybe we're seeing something where there's a protective effect of patients that are making it to the 1-year follow-up. And what was shocking to us when we looked at patients that weren't there at that 1-year follow-up and therefore not included in the sample because they couldn't answer these questions, when you look at the age difference, only 4.5 people less than the age of 50 ended up dying before that 1-year follow-up, which is actually still was a little surprising to me. It's that high. But really, when you look at that older age group, we're really seeing that dichotomy and that weird effect. 20% of these patients actually did not make it to their 1-year follow-up. And then you start looking at the reasons why, and it's a pretty increased risk of, death was due to the ischemic heart disease. And then the other form of heart disease is how the ICD codes kind of collapse, which includes all the different types of heart failure. And so, what we're seeing, those two that were lower in our TBI cohort was over 17% of the people who had died. And so we think that that might be part of why we're having some of these weird effects. And it's something that we're starting to study a little bit more, that we have an analysis ongoing, just looking at the cardiovascular causes of death. Oh, hold on. So we also have a meta-analysis that is ongoing. I like to shout out to our last brain injury fellow. This is Dr. Mahasan. She will be starting in her faculty job up in Minnesota the beginning of next year. And then this is also Dr. Thakur, my statistician, who has been fantastic and working on a lot of this data for us. And so this is one that we ended up, again, doing a systematic review and meta-analysis to look at these cardiac conditions and see what's out there in the literature. And you can see for hypertension, there is that increased risk for it. Coronary artery disease, we're also seeing this increased risk in our meta-analysis. And so there is the effect that coronary artery disease seems to be more likely to happen in patients that had traumatic brain injury. And as you notice, our study is not on here because we only looked at heart attack, not coronary artery disease, a little bit more globally. Heart failure, again, with the meta-analysis kind of confirmed about what we found, except we actually saw that it was no difference, not protective. And then what was most striking was this cardiovascular mortality. And it is, to us, very fascinating to see that the adjusted hazard ratios for cardiovascular related mortality is 2.88. It's almost 3 times more likely than the general population to die of cardiovascular mortality. And so this is stuff that we, again, this is preliminary. We're still kind of finalizing some of the subgroup analyses and everything, but Dr. Mahasan has submitted this to AAP if anybody will be at that conference in February to see the results. So moving on to kind of like why we care about the cardiovascular disease after traumatic brain injury is that in the general population, it is very well known that heart health is brain health. And I've really loved looking at a lot of the American Heart Association statistics and everything, that they're really focusing on this. So we have to keep the heart healthy to make sure that we're aging appropriately. And some of the stuff that you see in the cardiovascular literature, and again, this is non-TBI, this is the general population, is that hypertension is actually associated with dementia. And you really end up seeing the midlife hypertension being associated with dementia, not as much the late life hypertension. And that really speaks to the need to, screen for this in our patients that are already at risk for dementia. Screen for hypertension earlier in life. They're at higher risk for hypertension, as I had just shown. And now that might be part of kind of the added risk factor that could be causing some cognitive decline later. The interesting thing with the late life hypertension, that's just looking at your systolic blood pressure, like diagnosing hypertension by a pretty standard way of doing it. But there's some evidence looking at orthostatic hypertension or hypotension in older adults, and also some blood pressure variability, which is something that we're going to be looking at in our lab in the TBI population, being associated with dementia later in life. So it's a little bit more nuanced. Blood pressure is actually a lot more complex than just getting those 2 variables that we get. What's also very interesting, and again, the general literature is that this one large cohort study that you see used a lot in the cardiovascular disease literature, the Cardia study, they enrolled people that were 18 to 30, had no prior cardiovascular history, and then they followed them longitudinally. And so when they looked at their 30-year interview, they actually interestingly found that patients who had developed cardiovascular disease before they were 60, worse testing on neurocognitive scores, they had accelerated cognitive decline when they got older in life, and that they actually had some white matter changes on MRI. And so that really highlights that there's this like interplay between the heart and the brain, and now, some of the data that we're showing, that we're seeing also then the TBIs leading to, damage to the heart. And so it's kind of an interesting cycle. So with that, this is some data that actually we published a number of years ago now in 2020 from the model systems that is kind of looking at this, like the impact of the cardiac conditions on outcomes. And this is looking at patients that had the cardiac disease or hypertension at time of injury or were diagnosed during their acute stay. And you can see that cardiac disease overall in general is associated with a little bit of a worse cognitive function, and it's a very dynamic portion of it. And then same thing with hypertension. You're kind of seeing that there's like hypertension definitely associated with worse functional. So again, a little bit in the TBI literature, but there's definitely a lot more work to do to kind of look at how these cardiovascular risk factors are impacting recovery. So with that, we kind of want to think about like, why are we getting the cardiovascular disease after traumatic brain injury? And this is something that there's probably a lot going on that is multifactorial. Thinking about like TBI is associated with chronic inflammation. You might think about, maybe people are having differences in diet and activity, though that may or may not be as much. Some of the medications we're using. And then the next focus of this talk is really going to talk about like autonomic nervous system dysfunction. And that's something that is part of what our lab is looking at and how that associates with recovery after brain injury. And there's a lot of really good literature in the general population looking at sympathetic nervous system overactivity being predictive of cardiovascular events later in life. And so with that, I'm kind of going to transition a little bit into this realm. The autonomic nervous system, I hope you are all familiar with, has the two different factors: the sympathetic nervous system, which is that fight or flight, and then the parasympathetic nervous system that we think of as rest and digest. And the two pretty much work in concert to help with regulating, the body and homeostasis. And this hopefully will be pretty familiar to people about how the parasympathetic nervous system is primarily coming from the vagus nerve that's up in the brainstem, coming down, innervates a lot of the organs. You do have a little bit in that in the sacral area. And then the sympathetics are coming, throughout the spinal cord, and you have that sympathetic chain. And again, is innervating a number of different areas in the body. It's, anybody that treats traumatic brain injury is very familiar with the paroxysmal sympathetic hyperactivity we all call storming. Up to 82% or 92% of individuals admitted to the ICU with a TBI will have at least one of these symptoms of sympathetic overactivity. So tachycardia, tachypnea, hypertension, fevers, sweating. And anybody that's seen this, when they're really having these episodes, they can get really, really sweaty. And, sometimes you can see posturing as well. It's something that it has to be considered a diagnosis of exclusion because of the fact that a lot of things could be causing these symptoms: infection, pulmonary embolism, drug withdrawals, especially alcohol withdrawal can cause a lot of this, drug intoxications. And so have to kind of think there might be something else going on, but it's, again, very, very commonly seen acutely after brain injury. What's interesting when you look at actual autonomic dysfunction and like just dysautonomia overall, POTS, the postural orthostatic tachycardia syndrome, is like a classic one that you can see. But these are symptoms of like actual just autonomic nervous system dysfunction. You can get dizziness because like blood pressure and heart rate fluctuations are happening. Same thing with headaches. Patients can be irritable, startled easily, photosensitivity because the autonomic nervous system does regulate pupillary dilation. You're having a little bit of elevated sympathetic overdrive. Pupils are a little bit more dilated, and so that will make you sensitive to light. Heat insensitivity, changes in sweating, not tolerating exercise as well because of, again, having difficulties regulating that heart rate and blood pressure. And then people sometimes say that they're having brain fog or some cognitive stuff. And I put this up here just to think it's such a fascinating concept that this is something that people can be experiencing just from autonomic nervous system dysfunction. And a lot of these symptoms are ones that we think of are TBI related or especially concussion related. And some of these might actually really just be kind of thinking through, it could be the autonomic dysfunction that's happening as a result of the injury to go with that. I want to just kind of mention some of the ways that you can measure this heart rate variability. I feel like is really, you hear a lot about in the literature. It's on a lot of wearable devices now, plus minus on the utility of getting it on a device, but you can track where yours is in general over time. And what it is that you're looking at the variability of the actual like time between the R and the R's. So those are the big peaks. So you can see this would be considered normal sinus rhythm, but you can see that there's a little bit of variability between them. And so that's what heart rate variability overall refers to. We had a scoping review published earlier this year where we just wanted to just look at what's out there in heart rate variability after traumatic brain injury. And when you look at the literature that's there, in this study, we found 63 studies that looked at heart rate variability in TBI of any severity in human subjects. And we found that heart rate variability measures were typically lower in patients with traumatic brain injury than controls. I say typically because there's a lot of different measures that can be taken from heart rate variability that I'm not going to go into that kind of nuanced stuff, but for the most part, a lot of them were lower. Lower heart rate variability very acutely after severe TBI, and this is pretty much like early within the first few days of injury in the ICU, associated with increased mortality. And that's probably just a marker of how disrupted the autonomic nervous system is and kind of that connection between the brain and the heart, that those patients are more likely to die. And then there is a lot of very inconsistent findings looking at heart rate variability measures and symptoms that patients had, as well as kind of the long-term functional cognitive outcomes after brain injury that we are really interested in. And that's something that, when you look at the studies, there's a lot of lack of standardization of the techniques, the equipment being used, and even participant factors. And that means that some studies were having patients in a certain position. Some were fasting people, some were doing it over, a different period of time, doing it with exercise or anything. And a lot of things can actually impact what your data collection is going to look like. Even as much as the way patients are breathing can actually impact the heart rate variability. And so that's something that just have to keep in mind when you look at these studies, why we're getting so much heterogeneity of the results. So just thinking about the autonomic nervous system, okay, it mentioned that it's, you see the decreased heart rate variability being associated with mortality. What about other outcomes? And there's really not much literature out there in TBI. So this study I just am going to mention, it's a nice study of aneurysmal subarachnoid hemorrhage. So these are your spontaneous subarachnoid hemorrhages. Patients are randomized to a stellate ganglion block, which will block the sympathetic nervous system. And that's, done, it's in the neck. And so it really decreases the sympathetic nervous system activity. Or standard of care alone, and they had listed this as NSGB because it's no stellate ganglion block in their study. What they found was that people that had this stellate ganglion block, so they decreased their sympathetic activity, actually did better functionally and less likely to have hemiplegia 6 months after the subarachnoid hemorrhage than the controls. And hemiplegia after an aneurysmal subarachnoid hemorrhage is usually related to some secondary infarct that you're going to see in the brain. And what was really interesting in looking at their data is that they looked at blood flow velocity. So they looked at both the middle cerebral artery, which is the MCA, and the basilar artery, which is the BA. And you see that though everybody's, the blood flow velocity is going up, you're actually seeing that the stellate ganglion block, which is the shaded gray, doesn't have as much of an increase. And the blood flow velocity typically is going up after a subarachnoid hemorrhage, kind of indicating that there's some vasoconstriction and vasospasm with it. So think about if you take a hose and you kind of put your finger at the end of it while it's going, the water keeps coming out a lot faster because, it's smaller area. And so that was an interesting thing that they found, that it's suggesting that there's something going on by the autonomic nervous system and the blood flow. And it does make sense kind of physiologically. Overall, it's in general, you see that the sympathetic nervous system ends up innervating the blood vessels in the brain. Actually, both the sympathetic and the parasympathetic do in the brain. Whereas in the peripheral vasculature, it's just the sympathetic nervous system. And so you see if the sympathetic nervous system is firing and it's active, it actually helps to constrict the blood vessels. And so you can see in this figure with vasoconstriction, less blood is coming through. And so you're going to have less blood flow. And that's contrast to the parasympathetic nervous system, which is actually going to do the opposite and cause the vasodilation. And so with the vasodilation, once it goes back, you can see more blood is coming through. And so you're having increased blood flow. And the reason this is really important is cerebral autoregulation. And what cerebral autoregulation means is that your brain is able to maintain a steady state of cerebral blood flow, which is the CBF on the side, so that's the y-axis, like over a very long period of blood pressure. So that's the mean arterial blood pressure is on the bottom. And you can see there's a pretty wide range where you're having really fairly stable cerebral blood flow. What happens if you get to a point where the blood pressure is pretty low, you end up getting to a maximum dilation, and then you end up seeing the collapse of the blood vessels. And if you think about it, that's our orthostatic hypotension, or when patients pass out because they're hypotensive, that's what happens. And that's why, you get them, lay them down, put them in Trendelenburg, and help kind of get that blood kind of flowing back to the brain and opening up the blood vessels. So that's what happens if you have too little, you get to max dilation, you have too little blood pressure. On the other side, you end up seeing, like, at some point, you're going to maximally constrict the blood pressure or the blood vessels at a certain blood pressure. And then once you go past that area where you can auto-regulate, now you're going to end up having hemorrhagic strokes because the blood flow is going, you can only constrict so much, there's going to be too much pressure on those vessels, and then that's where they have that issue. So that's in the normal brain. Your brain is able to do that after such a nice wide range of blood pressures, which is great. After brain injury, this is pretty impaired, and that is a little bit of a problem, and that might be why we're seeing some of these issues. I will show you some data that was done some early, just looking at the blood flow and cognition, and this is, just to highlight why it's really important for that to be regulated. You can see in this study, they took 3 months after traumatic brain injury, moderate to severe injuries. They looked at cerebral blood flow with a transcranial Doppler. And you can see that at the end of the patients who have the highest blood flow, lowest duration of post-traumatic amnesia. So this is great. Like, these patients, cognitively were looking a little bit better, had earlier cognitive recovery, whereas patients that were having this lower amount of blood flow still in PTA longer. And so what was interesting in this study, they looked at the overall white matter tracts and just overall brain volume, and they found that this was irrespective of how much atrophy there was. And so the brain blood flow is really important to have, the brain functioning well. So to talk about some of the stuff that we're doing, I first want to give you a little bit of a background of the acute care research. So I had mentioned, we have this nice normal autoregulation. One of the other things that also is going on in the brain is that your intracranial pressure is actually changing in response to your mean arterial blood pressure. And typically what you end up seeing is that as the mean arterial blood pressure is increasing, your ICP is decreasing a little bit, or at worst, it's going to stay stable. It should be pretty either negative or really not hitting zero. And again, that ends up getting really dysregulated after traumatic brain injury. This is some data that was done in the acute hospital. There's this big center TBI study that's a big longitudinal cohort out in Europe that has done a lot of work on this measure in particular for cerebral autoregulation. And what you see on this is that they had looked at up to 10 days post-injury. And you can see on the bottom how many samples were in each one. I will say that this measure requires an ICP monitor, and an arterial blood pressure. And so that's why you don't see as many early, and then why it ends up going away kind of later is that these patients have to have this type of imaging in there or this type of monitoring. But what you can see is that of the people who had really high in the first 5 days, higher PRX ended up being associated with worse outcomes. And they found that it was really in the first 5 days more likely to be fatal if the PRX is impaired. And by impaired, they mean positive. What's interesting is that when you get to this whole point, they talk about how there's no difference in the functional survivors or the fatal outcome once you get past that 5 days. But really, their definition of functional survivors is a GOS of 3 to 5, which really, if you look at the GOS, 1 means that somebody's dead, and 2 means that they're vegetative. And so 3 could be as minimal as minimally conscious and just fixating. And then 5 is all the way up to completely independent. So they said that there was nothing here that actually correlates with outcomes, but if your outcome is so gross as in dead or vegetative versus everything else, it's really hard to kind of know how this measure and how this autoregulation might impact kind of long-term outcomes. And so with that, I kind of highlight again what all the literature in the center TBI that they've looked at this measure. Again, PRX higher is more likely to have bad outcomes, again, dead or vegetative. They find that there's an increased risk of a lot of these intracranial complications. So ICH expansion, edema, secondary ischemia. And then really importantly, this measure doesn't respond to any of the traditional treatments. So anything to kind of decrease the ICP, like the hypothermia, hypoventilation, and high levels of sedation, don't do anything. And then any of the vasopressors to maintain the perfusion don't impact it as well. And so there's something going on with autoregulation that just the traditional means of doing it aren't working. And so that's why our research is really focusing on trying to understand why this is happening and thinking that the autonomic nervous system might be playing a role. So with that, I'll kind of transition again. Our big research is looking at ANS dysfunction and how it's associated with the autoregulation, and then also look at how that's associated with long-term outcomes. I do also want to put an acknowledgement to my co-PI. This grant was funded with both of us as co-PIs, and we unfortunately lost him earlier this year. So we are doing all this work in his memory to, make sure it lives on. So with that, this is kind of our whole conceptual framework. We know that traumatic brain injury is associated with the autonomic nervous system dysfunction, as we've shown. And clinically, you really see that it's the increased sympathetics, lower parasympathetics. And then we do know you see that cerebral autoregulation, which is being disrupted, which overall will decrease some of the blood flow. And so our whole thought is that what's probably happening is that it might be that the traumatic brain injury is causing the ANS dysfunction, and that's the underlying pathophysiology for this autoregulation. So we're really trying to tease that out in this grant. Then we really want to look at how this is associated with the physical and cognitive disability. And the reason I have this dashed line here is that though we believe that this is associated with physical and cognitive disability, I'm not 100% convinced that that is directly causing it. And I'm thinking that it might be kind of going through this autoregulation. So that kind of gives you a little bit of a framework of what we're doing. So this study, it's one we're enrolling patients with complicated mild to severe traumatic brain injury while they're admitted to inpatient rehab. And we're doing follow-ups at 3 months, and 3 months is indexed to when their injury happened, not based on when we did this assessment. 6 months, 9 months, and a year. And we are also doing healthy controls where we're indexing the 3 months based on their baseline assessment. This cart that you see is actually how we are doing this in the rehab unit. We have a mobile lab that goes to each of our rehab units to get this data directly from the patients on the rehab unit without having to have them be sent to our inpatient lab or our outpatient lab. And then we're doing all our follow-ups and our healthy controls at the outpatient. We're looking at, like, again, these are model systems measures just because we know we have patients that are dual enrolled, and we're really excited to be able to get some of the free 2-year outcomes from model systems. And so we're looking at the BTAC for cognition, the GOSC, and the disability rating scale. So I'll give you an idea of how we're ending up doing this. So I mentioned the PRX is done very invasively in the ICU. That's why you don't see any literature looking at this longer than the first few days. There is a way to do it non-invasively where you get the cerebral blood flow, and this is actually a graduate student that's with us right now. So she let us use the photo that they've taken. This is a transcranial Doppler that's hooked up to the probe. We're getting the middle cerebral artery, and you can see this is like a tracing. I do believe that this is her tracing, and that's pretty typical of like a good artery where you can end up seeing the good blood flow, and it has this kind of peaks and then goes down with that. We're also doing arterial blood pressure, and this is, again, very non-invasively. This is a finger blood pressure cuff that you can see right there, and you can actually get beat-to-beat blood pressure with it. So it's a really cool assessment, again, doing this very non-invasively, but kind of mirroring what you would get in the ICU. And so with those two pieces of data, there's some software and algorithms that are able to give us a non-invasive pressure reactivity index. Heart rate variability is just real simple. We're doing 3 late EKGs, which is pretty standard for being able to do that. And then one of the really unique measures of this is looking at the muscle sympathetic nerve activity. So this is considered the gold standard to be able to assess the sympathetic function. What you do is you end up having 2 very tiny, and they're very small to even see. These needles are about the size of acupuncture needles, and they're recording electrodes. One ends up going just in as a reference, and the other one ends up going into the radial nerve. And I'll show you in the next slide how we do that. And what it's doing, you can see, you go in, you're getting the recording, and you actually can measure sympathetic nerve bursts from that. And so this is a technique that we're doing. Obviously, you guys are probably thinking getting this in patients with brain injuries in the rehab unit. We have gotten one, I'll show you the data, but it's a secondary measure that we have decided that if the patient is amenable in the hospital, we will get it. And if not, we will wait till they're a little bit more cognitively and behaviorally able to participate in that. The rest of the measures we really have not had issues with getting from that. This is how we have the setup. This is actually just kind of some images from an outpatient lab. You can see we're doing it ultrasound guided to get into the radial nerve. And you can see on this picture with the ultrasound, this is the humeral head. radial nerves there, and you get the microelectrode in that way. And so we're able to get the signal that way. We have, again, we can take this all in our portable lab as well. We've got a completely laptop-based portable ultrasounds to be able to get this measure. This is some pilot data that we have from the subject that we were actually able to get nerve in the hospital. He was very calm, cognitively good at the time we tested. Subject had a severe TBI with a GCS of 3 at the scene, and he was about a month post-injury. So he's the top 1A, and then the bottom in B is just a representative sample of patients that were age and sex or that age and sex matched to him. And so this, what I'll give you kind of to see, the red line is the raw nerve. So it's obviously very messy and a little bit challenging to kind of pick out, but this is kind of what we get for the integrated nerve on our software. And what you're looking at are these spikes, these bursts. And you can see, like just visually seeing it, there's a lot more bursts on the top recording than the other. You also see that there's a lot of these are coupled or, sometimes even tripled with that. And so we're having very much more increased burst firing. So his was, I believe, 37 bursts per minute. Whereas the healthy controls out of the 10 we had, their age and sex match, the average was 17. So it's definitely increased. This patient we know had increased sympathetic nerve activity from that. So, and that's, as far as we know, the first time it's ever been recorded in a hospital. So this, if anybody's at ACRM, one of my coordinators is actually going to be presenting this data at the conference at one of the posters. And it just gives you an idea of our lab setup. This is a healthy control that had come in. He was doing the full assessment. The female right here that's doing the ultrasound, she's getting the MSNA, is our postdoctoral fellow, Dr. Champagne. And then the man standing right here is Dr. Young, who's a physiologist and is my new collaborator on this work. And so they've been really busy lately, especially. We've had an uptick in enrollment, just I think it's just the time of year. So you can get an idea of kind of how our lab is set up. Over here, this screen has our transcranial Doppler with it, and then you can see that she's got the ultrasound is getting in for the nerve. And then if you want to see like up at the top, this is kind of like all the recordings of everything all at once. And so that data is able to kind of go through this software to analyze and be able to really get some interesting stuff about like how the nerve is responding to the blood pressures or heartbeat and things like that. So big things to kind of take home from this is that individuals with TBI are obviously at risk for the cardiovascular disease and cardiovascular mortality. We do think that ANS dysfunction is one thing that could be doing it, and that's something that I really have interest in kind of going in future grants, which marries both of these two projects that we've been working on. The autonomic nervous system dysfunction occurs following traumatic brain injury, and it might be associated with the persistent symptoms and also for long-term outcomes, which we think might be related to the cerebrovascular blood flow. And with that, I just want to kind of give a shout out to my lab. Obviously, I am not doing this all on my own. So this is the lab that we have between our lab staff, our trainees that we have, and everybody. And so it's a great group to work with. And I'll take any questions. All right.
Very
Nothing in the
cool.
chat.
I mean, are you thinking any possible interventions down the road or any ideas?
That's the one thing that eventually, so the first thing we want to do is really kind of get an idea of the physiology. And so one thing, when we pitched this to the inpatient teams, is that they really did not want us to hold any medication. So we aren't holding any medications. We're looking at kind of, we'll have a big enough sample that we'll probably be able to get some idea of like beta blockers versus not, to see what like the data looks like, especially with the longitudinal follow-ups as patients come on and off medications. And then so that's where I'm kind of thinking is that once we get a better sense of what's going on in there, then you think about like, is there something we need to do kind of pharmacologically and go that direction? Yeah.
It's a great talk. I'm TBI is not my area of research. I'm more in the SCI side, but I feel like I learn a lot from here, especially the AMS, autonomic dysfunction, which is an issue with the spinal cord injury population. So I'm just curious to see that you focus on a relative acute traumatic brain injury. So I'm wondering, is this phenomenon also occur in the chronic spinal TBI?
Yeah, that's a great question. So this grant is definitely very focused on the acute, and we're just trying to see what's there for the long term. I do have a grant that we're going to be putting in by the end of December. That's good. That's actually an institutional grant that we got accepted on the LOI stage, that we actually want to bring in some of the patients from model systems, because we've got that really nice, well-characterized trajectory of their BTAPs and their, function, and then also extend our collection. So with this grant, we're only looking at up to a year, and we're starting to get, some patients that are hitting that point right now that we want to start. If this other grant gets funded, we do want to look at, their 2 years and then bring in some patients from model systems to look at it from the chronic with it.
That would be very exciting, to see the trajectory. Thank you.
Yeah, and I'd be very interested to kind of see. I think the first thing, once we get a handle and have enough people that make it through that, I'm also kind of curious, are we seeing it like really acutely and then it's going down overall? Or are we, what my anticipation is that we're actually going to see probably a subset of people who do a normal, like it's high acutely, like, abnormal acutely, and then by a year it's recovered. But we might have some people that are even in that year point that are following that trajectory that it's not getting back to baseline. And that's where I'm very interested in seeing, like, are those the patients that are having persistent symptoms longer, or, not recovering as typically? Anything else? All right. I see nothing in the chat, so stop the share.